Hello, welcome to Chapter 8, Hemolytic Anemias, Enzyme Deficiencies. Let's do a bit of a review. Mature red cells depend on anaerobic glucose metabolism for energy. Usually, red blood cell enzyme activity is stable, and they have the appropriate amount of enzyme present for normal cell function. Here we have a normal peripheral smear picture. We know as cells mature, they start to lose their nucleus, their mitochondria, and their ribosomes. They can't synthesize any more protein or go under oxidative phosphorylation for ATP production. Now, when there is an inherited red cell enzyme deficiency, this compromises the integrity of the cell membrane, or hemoglobin, which leads to hemolysis. In 18.1, we have the enzyme deficiencies that are associated with chronic non-spherocytic hemolytic anemia. First, it lists the metabolic pathway that red cells use for energy. First, we have the glycolytic pathway, which uses 90% of the red cell's energy. The most common enzyme deficiency in this pathway is pyruvate kinase. The other enzymes listed below in this pathway are very rare, but it can be as a deficiency. The hexose monophosphate shunt pathway most commonly occurs with G6PD deficiency. It is the most common enzyme deficiency found within the red blood cells. Now let's go over how the pathways work. Let's talk about the hexose monophosphate shunt first. This catabolizes 10% of glucose. It maintains adequate levels of reduced glutathione, or GSH. This is maintained by the conversion of NADPH to NADP. And NADP is reduced back to NADPH by G6PD. This is very important because it protects the red blood cell from oxidative damage. It maintains hemoglobin in the reduced functional state and preserves vital cellular enzymes. Now, enzyme deficiencies in this shunt causes oxidation of hemoglobin, the formation of Heinz bodies. Now, the spleen might remove these Heinz bodies and you might see bite cells, and the cells will tend to hemolyze. Now let's look at the glycolytic pathway, or the Embden-Meyerhof pathway. Here, the red cell utilizes 90% of glucose. It maintains adequate levels of ATP needed for active cation transport across the cell membrane. It also helps maintaining the membrane deformability and maintaining the red cell's biconcave shape. Deficiencies here are decreased ATP and impaired cation pumps, which increases the fragility of the cell, leading to hemolysis. Now, the Rappaport-Neuerberg shunt, which is the pathway that sticks out of the glycolytic pathway here, provides red cells with 2,3-biphosphoglycerate, which helps deliver oxygen to tissues. Let's discuss the most common red blood cell enzyme deficiency, glucose 6-phosphate dehydrogenase deficiency. It was first recognized during the Korean War, where an anti-malarial drug caused hemolytic anemia. It is an X-linked inheritance pattern that's fully expressed in males and females with homozygous inheritance. There are over 400 worldwide variants, varying in levels of severity. Generally, patients are asymptomatic, except when they are challenged with oxidizing chemicals, drugs, severe infections, or certain kinds of foods, such as fava beans. With this deficiency, there could be a generation of impaired NADPH or impaired GSH. Here, cellular oxidants accumulate, leading to decreased solubility of hemoglobin. This precipitates to form Heinz bodies. Heinz bodies attach to the red cell membrane. We can see them here in this supravital stain. They are caused by an increased cation permeability, cell rigidity, and increased osmotic fragility. Now, usually these golf ball inclusions are removed by the spleen, creating bite cells. So progressive loss of the membrane may lead to a spherocyte or extravascular hemolysis in the spleen. Here's a peripheral blood image of a patient with G6PD deficiency. You can see the numerous bite cells in this picture. Eventually, with the oxidization of the membrane and passages through the spleen, the red cells can be removed and hemolyze, leading to intravascular hemolysis, which could lead to hemoglobinemia or hemoglobinuria. There can be a spectrum of clinical presentations with G6PD. Mostly, it's acute acquired hemolytic anemia, and most patients don't have any clinical symptoms or anemia, and hemolysis doesn't occur until they experience or are exposed to an infectious illness, a certain type of drug, or food. The hemolysis is variable. Again, it depends on the degree of oxidant stress, the G6PD variant, or the sex of the patient. With drug-induced G6PD, you have acute intravascular hemolysis 1 to 3 days after exposure, where the hemoglobin can drop down to 3 or 4 grams per deciliter. Usually patients experience abdominal or lower back pain, and you might have dark or black urine. Patients with G6PD, after the ingestion of fava beans, can experience sudden severe hemolytic episodes, similar to drug-induced episodes. Again, the variants depend on the severity and usually affects children 2 to 5 years old. The findings are general malaise, lethargy, nausea, vomiting, abdominal pain, chills, tremors, and fever. You may see jaundice if there is liver involvement, and hemoglobinuria after a few hours after ingestion. Another clinical presentation is hereditary non-spherocytic hemolytic anemia associated with G6PD variants class 1. You can find the class tables in table 18.3. Here you have low in vitro activity or markedly unstable variant that leads to a chronic type of hemolysis that's not associated with the ingestion of drugs or infections, although they can exaggerate the hemolysis. Hemolysis here is usually compensated, so mild anemia with reticulocytes up to 35%. You can also have a clinical presentation in neonatal hyperbilirubinemia, where some neonates with G6PD deficiency show a severe hyperbilirubinemia. As you can see in the brain cross-section below, the left-hand side is showing that kernicterus in the brain, which possibly needed for transfusion therapy and phototherapy. So most variants of G6PD have no anemia and have normal blood findings until there is a hemolytic episode. Immediately following those hemolytic episodes in the peripheral blood, you can see polychromasia, the occasional spherocyte, small hypochromic cells, red cell fragments, bite cells, and here are some images of blister cells, which the hemoglobin is condensed to one side of the cell, leaving the other side transparent. You may also see reticulocytosis, increased leukocytes, and the breakdown of hemoglobin within the intravascular hemolysis, leading to unconjugated bilirubin and decreased haptoglobin. For definitive diagnosis, the timing is very critical. Usually it's performed 2 to 3 months after the hemolytic episode because you need the red cells intact in order to quantify the enzyme within the cell. So the most common types of cells are either the quantification of G6PD enzyme or molecular methods. As for therapy, no therapy is needed when patients are asymptomatic. G6PD deficient individuals should avoid oxidizing agents, foods that precipitate hemolytic episodes such as fava beans. When they do have acute hemolytic episodes, blood transfusion can be a therapeutic agent. Again, treatment for any underlying cause or infection, eliminating the causative agent if it is a drug, and sometimes with infants, exchange transfusion and dialysis may be necessary in certain severe cases. Other deficiencies and defects of the hexose monophosphate shunt include glutathione synthetase and glutamyl-cysteine synthetase, which cause deficiencies which reduce GSH. They're also associated with hereditary non-spherocytic hemolytic anemia. Another enzyme, glutathione reductase, catalyzes reduction of GSSG to GSH. And lastly, glutathione peroxidase catalyzes the detoxification of hydrogen peroxide by GFH. Deficiencies are not associated with hemolytic anemia. Now, these deficiencies are very rare, but are worth a notable mention. Let's now discuss pyruvate kinase deficiency. So if we review, glucose is metabolized by pyruvate in the glycolytic pathway. Here, ATP is generated as phosphoenol pyruvate is converted to pyruvate with a net gain of 2 ATP. 2 molecules of pyruvate are formed from one glucose molecule. In PK deficiency, this reaction is slowed, resulting in a deficient ATP production. PK deficiency is the most common deficiency of the glycolytic pathway and the second most common enzyme deficiency of the red blood cell. It is autosomal recessive in its inheritance pattern, usually resulting in a chronic hemolytic anemia, either inherited as a homozygous or double heterozygous state, with over 220 mutations. Again, severe deficiencies are usually detected early in life. So, with PK deficiency, we have a decreased ATP production. So you are unable to maintain ATP, which causes cell membrane damage and failure of the cation pump. So you have a loss of sodium and potassium and a gain of calcium. Here, cells may dehydrate and become echinocytes as they pass through the spleen. Now, symptoms vary depending on the degree of anemia. There could be a block in glycolysis accompanied by an increase of 2,3-BPG. You might have 2 to 3 times increase in 2,3-BPG as the cells are trying to deliver oxygen to the tissues. This is how individuals tolerate the anemia. You may have intermittent hemoglobinuria, you might produce gallstones, or you might visually see jaundice. In neonates, this could be very severe, the jaundice, and life-threatening. In older children, there might be a need to remove the spleen in order to stabilize the hemoglobin level and decrease the need for transfusions. Now, here is a blood smear of a patient with PK deficiency. You are noting that there are lots of echinocytes, acanthocytes here, target cells, and irregularly contracted cells. Howell-Jolly's bodies are also present with a couple nucleated red cells. Normally, with these patients have a normocytic normochromic anemia, and the hemoglobin ranges from 6 to 12 grams per deciliter. Reticulocytes range from 2 to 15%. After splenectomy, they could be as high as 40%. Here is very important to note that there are no Heinz bodies or spherocytes, as hemoglobin is not affected in this condition. You will have normal osmotic fragility here, but you might see unconjugated indirect bilirubin as hemolysis is more severe. Now, with testing for PK deficiency, molecular testing has definitely replaced the enzymatic tests. As for therapy, there's no specific therapy. You could increase hemoglobin levels with transfusions or remove the spleen completely. Other enzymes that are deficient in the glycolytic pathway include glucose phosphate isomerase deficiency, which is the second most common disorder of the glycolytic pathway. Here, the hemolytic anemia will respond with splenectomy. Hexokinase deficiency is the first enzyme in the glycolytic pathway. There are two types of this kind of deficiency. One that responds to splenectomy, and one hemolytic anemia with other abnormalities. Phosphoglycerate kinase deficiency is an X-linked disorder that causes hemolytic anemia and mental retardation in males, less severe forms in females. Phosphofructase deficiency causes hemolytic anemia and myopathy. Triose phosphate isomerase deficiency is a very severe hemolytic anemia, and most patients die in infancy. The last type of enzyme disorder involves red cell nucleotide metabolism. Pyrimidine 5 nucleotidase contributes to the degradation of nucleic acids within the cell. Here you have a buildup of pyrimidine nucleotides, which decreases adenine in the nucleotide pool. This is autosomal recessive and results in a severe hemolytic anemia, which is unresponsive to splenectomy. And you exhibit coarse basophilic stippling, as you see here in the peripheral slide.